Hello, everyone, and thank you so much for tuning into our Ask the Doc segment. Now, the Ask the Doc segment is part of our calendar countdown for the 2020 virtual Walk to Cure Arthritis, and this is a nationwide virtual walk that is happening on the Facebook page of National Arthritis Foundation, and that will be at 4 p.m. Eastern Time on Saturday, May 16. So I am so pleased to welcome, well, first of all, I'm Tammy Barboza. I'm representing the Rhode Island market of Arthritis Foundation. And speaking of Rhode Island, I'm so pleased to introduce our special guest, Dr. Edward Reardon. And Dr. Reardon is a rheumatologist based in Warwick, Rhode Island. He has been practicing rheumatology for more than 30 years. Dr. Reardon, thank you so much for joining us.
Well, thank you. I appreciate it.
Thank you. I'm just really thrilled to have you here today because I know our viewers are going to gain such knowledge and expertise of your more than 30 years in rheumatology. So let's dive in to the first question, and that will be, what are 10 examples that you can provide our viewers of various forms of arthritis that represent a pretty broad scope of this disease?
Well, there's over 100 kinds of arthritis, but typically the rheumatologist sees about the top 10 or 20, the more frequent arthritides. The most common arthritis is osteoarthritis. That's affects about 10% of the population, over 30 million people. Then the prevalence drops off considerably when we get into the more autoimmune-based arthritides, such as rheumatoid arthritis. There's lupus. There's various kinds of psoriatic arthritis. We have ankylosing spondylitis. We have the arthritis that's associated with Crohn's and ulcerative colitis. We have crystalline arthritis, such as gout and pseudo-gout. We also have infectious arthritis in two forms, one where the germs actually go into the joint, that's called septic arthritis. And there's also one when you get an infection, you get a reactive arthritis from something like a GI infection, a gastrointestinal infection, or a urinary infection, or an STD. Or then you can also get a reactive arthritis from what we know here and very common is Lyme disease. So there's many different kinds, but those are the kinds that we typically see the most of.
Thank you. It's pretty amazing to have more than 100 forms of arthritis, indeed. Let's focus on osteoarthritis, known as OA, and rheumatoid arthritis, known as RA. What are the true differences between those two types of arthritis?
Well, that's a really excellent question, and that's primarily what drives the patient to have a consult with a rheumatologist. Osteoarthritis is the typical mechanical wear and tear on the joint that everybody gets if they are lucky enough to have a certain amount of birthdays. They have breakdown of the cartilage, the water in the joint called synovial fluid changes its form, the tendons and the capsule around the joint, they change, and it affects 10% of the population or more. So most people are going to get osteoarthritis if that becomes symptomatic in their typically 50s or 60s, depending on their hereditary background and how many injuries and their weight. The big thing about osteoarthritis is that it is confined to the joint. It does not go into the other organs in the body, and it has nothing to do with the immune system. On the other hand, on the converse, you have rheumatoid arthritis, which is the exact opposite. Rheumatoid arthritis is not really a disease of old people, although old people can get arthritis. You get rheumatoid arthritis at any age. Even little babies can get rheumatoid arthritis. So that's when what we have is a dysfunction of the immune system. Now, the normal immune system, I'm making a example. Let's say you go and you step on a splinter in your foot, and you get the splinter out, but you leave a part of the splinter in that you don't know about. Over the weeks to months, it starts to get red, it starts to get swollen, it starts to develop fever, that pus comes out. That's a foreign body reaction. That's a normal immune response. That's normal, it's good. Now, in rheumatoid arthritis, the immune system becomes dysfunctional. And what it starts to do is sense the body, the self, as foreign. That's the definition of autoimmune. It goes against your own body. So the immune system starts to attack the joints like it would a splinter or attack or something, or a germ in your body. And we don't know what causes it, but we know two facts. One is that there are certain people that are hardwired to get rheumatoid arthritis genetically. That's been established. However, all those people that are hardwired to get rheumatoid arthritis, only a fraction do. And that's something to do with an immune trigger in our environment. So it's a combination, it's a perfect storm of genetics and environment linking together and setting off an immune response primarily against the joints. And some of the triggers that they think are cigarette smoke, bad dental hygiene, stress, etc. But we don't know for sure, but that's what we think. And the other thing is that not only does the immune system attack the joints, but it can also attack other organs. It can attack the eyes, it can attack the ears, it can attack the nose, the throat, the lungs, the heart, the kidneys. Almost all organs can be affected with rheumatoid arthritis because of the immune system being dysfunctional. So there's a vast difference between the two, with rheumatoid arthritis not being as prevalent, but being, much more devastating. For it ruins the quality of your life, but it also has a shortened lifespan. So
Yes.
those are the two big differences.
Dr. Reardon, is it possible for someone to have both OA and RA?
Yes, it is. Most of us, as I had mentioned in the prior question, most of us, unless we are extremely lucky, are going to develop osteoarthritis if we are lucky enough to have enough birthdays. Women start to become symptomatic right after menopause, 50, 55, 60, they start to become symptomatic. Men have a tendency to be a little bit older, more in the late 60s to early 70s before they become symptomatic. But that's not everybody. If you're heavy, you'll get it earlier. If you've had injuries to your knee, if you have a football injury, a skiing injury, you're more likely to develop arthritis in that joint because of the injury. But you can also get, rheumatoid arthritis at any time. And yes, the two can coexist.
I see. What are some of the commonly known or used medicines to treat arthritis?
Well, that's a very, there's a question that could have a very long answer to it, but I'll try to be as succinct as possible. The treatments for arthritis are in two basic categories. One are medicines that manage symptoms. You have a sore knee. You go to the drugstore, you buy some ibuprofen and Tylenol, and you take these medications and wait for the knee pain to get better. That's symptomatic treatment. If the knee pain's from arthritis, it treats the symptoms. It doesn't stop the disease. It just makes the inflammation go down. The wear and tear is going to continue. Now, that's the big group. So the symptom control drugs are primarily drugs like the anti-inflammatories, the descendants of aspirin, ibuprofen, Aleve, Voltaren, those type of things. They're also used in conjunction with a simple pain reliever called Tylenol. You can take those together. You can also use other skeletal muscle relaxers. You can use opiates to control the pain, but they treat pain, but they don't modify the disease. That's the one big lumping. Okay. The other big lumping is what we call the disease modifiers. These are the ones that actually retard the progress of the illness. For osteoarthritis, even though it's the most common arthritis, there are no disease modifiers on the market today for commercial use. They are being developed, but they're not available to the rheumatologist. However, there is over 20 disease modifiers available for rheumatoid arthritis, and there are a couple of disease modifiers that are available for lupus. And there's one disease modifier that can reverse tophaceous gout. So those are the two big lumpings of groups of medications. If you want more information about that, you go to arthritis.org and they would explain all those medicines for you.
Thank you. You did a great job consolidating that answer, because I know we could spend an entire episode just talking about medicines.
Which is a wonderful thing, since we have so many great drugs now.
Let's segue into one of my favorite topics of all time, which is food and the importance of nutrition. And so let me ask you, how important is nutrition with regard to arthritis and the many forms of arthritis?
Well, nutrition is very important in terms of helping manage arthritis. First of all, is that this country is really bad on nutrition. Obesity is rampant, and that's, first of all, not good for anybody, and especially those people that have an underlying arthritic condition. To control arthritic symptoms, now this is not evidence-based per se, but it is anecdotal that in some foods do help arthritis, typically foods that are anti-inflammatory. And the big one is fatty fish, such as salmon, that contain the omega-3 fatty acids and vitamin D. That they've been touted to be very helpful for people with inflammation as a result of arthritis. Also, a lot of fruits are good. Spinach, broccoli, berries, all those type of things have been touted to be helpful in controlling systemic inflammation as far as arthritis. That being said, there are also walnuts and spinach, those type of things. That being said, there are a lot of bad foods for arthritis, and typically, everybody knows what they are because that's what we eat in this country. Anything fried, French fries, fried chicken, not good. Anything containing monosodium glutamate, that's not good. And any type of carbohydrates, white bread, white fish. The old thing is, if it's white, don't bite. That's one of the things that is touted to elevate your inflammation level. But following all these diets, it can be very, very daunting to patients about what to eat. So I have my own little spin on food, and it's really easy to remember: chicken, fish, fruits, and vegetables. If you stick to those foods, you're probably going to be right. So that's how I would like to sum up that question.
What about whole grains?
Whole grains are good. They have anti-inflammatory properties.
Great. Let's talk about self-care, because there are some things that people with arthritis, myself included, can do to help alleviate symptoms. What are some of the, say, top 3 self-care strategies that you can offer as advice?
Well, I'm kind of an exercise fanatic, so I would say that diet and exercise and joint protection would be the top 3. We talked about diet and what we did with that, but controlling weight is so important for all people, not just those with arthritis, because not only is it the mechanical, obvious stress on the joints, but it also, adipose contains, and I'm going to use these big words and I'll explain them later, contains pro-inflammatory cytokines. That's why people that are obese have more cancer. People obese have more arthritis. People that are obese have more heart disease. People that are obese have more cancer, because inside the adipose tissue is all these bad pro-inflammatory cytokines, which we can call the evil humors, that perpetuate the inflammatory response. So controlling your weight is key. And and how do you control your weight? By keeping your metabolic rate up. And how do you keep your metabolic rate up? By diet and exercise. You eat protein, that raises the metabolic rate, that suppresses appetite. You avoid carbohydrates, that lowers the metabolic rate, increases appetite drive. And then you exercise. And the exercise recommendations for this country is 30 minutes, 5 days a week. I think that's not enough. I would recommend at least an hour, 6 days a week, of something that would protect your joints, something easy like walking, stretching, stationary bike, swimming is probably the best exercise for people with arthritis. And why is that? Because in a swimming pool, we're 90% weightless. I weigh 150 pounds. In a pool, I would weigh 15 pounds, because that takes all the pressure off the spine, allows the spine to elongate, allows the joints to separate, and allows all the blood flow to go in and help keep the joint healthy without harming. But you should consult your physician. You should consult a personal trainer or a physical therapist, somebody that can help the patient exercise in a safe, proper way. And here's the big thing that I see in my practice is that people take up exercise and they overdo. If you haven't been exercising, the last thing you want to do is go get gung ho and get hurt. Then there'll be no exercise. So I would say ease into it, consult somebody that's an exercise specialist. I do my own exercise advice because I love exercising. But if your doctor's not comfortable with it, you can refer you to a physical therapist or a personal athletic trainer, someone that can guide you in a safe exercise program. But diet and exercise and joint protection, those would be the things that I would be um, most helpful. And the other thing, of course, in this whole COVID-19 thing, stress reduction, proper sleep hygiene, all the, if you get a good night's sleep, that makes your day better. It's hard to have, sleep deprivation is a form of torture. So if you're not sleeping properly, that should be addressed as well, because that can make you gain weight and make you stressed out.
So I know that you enjoy swimming. You just shared that with us. And I understand that you enjoy another form of exercise in the way of dancing. Is that correct?
That's correct. I'm an avid ballroom dancer with my wife, and not to brag, but I won Dancing with the Doctors in 2016. I won the coveted Mirror Ball trophy. It was a victory like no other.
Congratulations, and I'm assuming that's similar to a Dancing with the Stars?
It is, yes, exactly. A lot of fun.
Wonderful. Dr. Reardon, if and when you need to refer your patients to other healthcare professionals, what types of professionals would they be, and for what are the common reasons behind that?
Well, I would say that my most common referral that practically all my patients are given the opportunity to go to is a physical or occupational therapy evaluation. Because I look at that as their lessons to get going on their new chapter of their life now that they've become my patient, of diet and exercise. And so that's, what everybody's offered that. There's nobody that hasn't been exercising that can't benefit from a therapeutic exercise program for their arthritic condition. That being said, what do I share with most patients? Well, I share a lot of patients with podiatrists. A lot of my patients have chronic nagging foot problems, which hampers their ability to exercise. So I do a lot of people either podiatry or an orthopedic evaluation. I also sometimes refer to a physiatrist that they need a more comprehensive exercise program that would, facilitate more testing and more expertise. And then I guess that would be the most. And I also consult neurologists a lot because a lot of my patients have neuropathic pain as well. They have neuropathy, or they have radiculitis, or they have carpal tunnel, or something like that, or tarsal tunnel. So those are the big referrals for me.
So quite a number of different types of healthcare professionals.
Yes.
Absolutely. And if one of your patients is in need of surgery of sorts, is there certain criteria that you go by when you feel that one of your patients is at that crossroad?
Yes. Well, I'm glad you asked that question because from where I sit for 30 plus years, I have a tendency to see a lot of people that got worse with surgery rather than better. So the first thing I say is this, nothing surgical can replace the God-given parts that you've got that you should be taking care of. Your body is your temple, and you should be using that mantra. So we avoid surgery at all costs. That happens, and then all of a sudden they can't. The big limitation is pain. If you have intractable chronic pain that has failed all conservative treatments, then yes, we would consider surgery. The big discussion, of course, is knee and hip replacement. My thing is that, you wait to the very, very bitter end to get the knee and hip replaced. We do everything we can, from PT to shots to pills, anything to keep you from getting that surgery until you reach the bitter end. And one of those things is you get a lot of rest pain. And if your knee starts throbbing at night and you're not even on it, you're having bone bruising underneath the cartilage. Yes, now it's time to contemplate getting the knees and hips replaced. Also, back surgery. People, back surgery and neck surgery are designed to take away primarily the pain. People may disagree with me. Primarily the pain radiating down the buttocks and the legs from the back, but down to the hands and arms from the neck. And that that surgery is designed for that. You're still going to have a backache, even if it's successful. You know, and you have to own that when you go in that. You're still going to have a backache. It's not the leg pain or the arm pain. Hopefully, will dissipate over time, but you're still going to have. They're not cutting out the arthritis. They're taking away the pinching or the entrapment of the nerve roots. That's a common misconception. So, but overall, we tried here to utilize all the natural healing powers of the body to make the body better before we go into surgery.
So surgery as a last resort, if you
As the
will.
last resort, yes,
Yeah.
because we can always get worse. You know, people don't talk about that. So,
There is one thing that each of us living has in common in various amounts, and that's stress. And they say stress can have such a rippling effect on one's body and one's emotional state. What is the relationship between arthritis and stress?
well, stress sets into motion a whole cascade of chemical reactions, and in those chemical reactions, there's a lot of hormones being released that can set the immune system off and make the immune system actually more active than it already is. You've got an arthritic condition. If it's autoimmune based, your immune system is already malfunctioning. Now it's going to be more amplified. So control of stress is paramount. Now that's sort of a platitude because the stress is part of life. You wouldn't want to live in a world without stress, but instead of being overstressed, you want a state of eustress, EU stress, just the right amount of stress to keep you sharp, keep you leading a meaningful life, but without harming the body. And for everybody, that's a tough formula to navigate. But with diet and exercise, proper home life, proper family life, getting proper sleep, the nice work-life balance that we try to get, all those things help you control stress. And the other thing now meditation's becoming, big now. Just letting your body just mellow out. Like my type of meditation would be walking and listening to music. That would be that's my type. Rather than sitting in the chair and just staring at a wall, that wouldn't work for me because I can't sit still. So but I mean, you've got to find your own type of meditation. Swimming laps. People say, how do you get in there and go swim back and forth? It's so boring. I said, it is boring, but it's a form of meditation. I'm not listening to anything but the water going in and out of my ears. So yes, everybody's got to find that way to do that. But controlling stress, and if there's something that really is eating at you, address it. Don't ignore it. Be it if somebody at work or somebody in your family you're not getting along with, try to deal with that and get things out in the open, talk things out, and communicate what the problem is. Not easy.
Not easy,
No.
but worthwhile.
Right.
Absolutely, yes. Some of us at times hear the term personalized medicine. What does that mean?
Personalized medicine is that where they take a patient and they analyze their genetics and they analyze their history and they perform tests on their body and they find out what diseases that they're predisposed to, would be a cancer or heart disease, and then they go ahead and look into that, order the proper. They may go ahead and order testing that wouldn't be routinely done. Say you've got a strong history of heart disease, you might get you may get a stress test at age 30 or an echogram at age 30 because that's in your genes or that you're at risk for that. So that's what personalized medicine. They look at an individual from a genetic and environmental sense, and they order appropriate testing to mitigate that person developing that illness.
I see. That's so interesting.
Yeah.
Dr. Reardon, as a rheumatologist for more than 30 years, I am sure you have seen advances in the field of rheumatology. Can you share with our viewers maybe 2 or 3 of those advances that you've seen, say, over the last 10 years?
Sure. I would say, first of all, I'm going to start out with a non-rheumatic, God-given gift, which is the internet. I can remember going to libraries and looking up library cards and pulling out magazines and, having to read the magazines in the library because they couldn't take them out and all, but now you have, the world at your fingertips in all disciplines. So Like today, I'm preparing for this talk. I'm on the internet. What would have taken me 3 hours, I was able to do in an hour. So that really changed the scope of my rheumatologic practice. Now, getting more specific into rheumatology, of course, the treatment of rheumatoid arthritis is probably the biggest change, because when I got out in 1989, methotrexate was the big drug. That was a big wonder drug. That was released in '88. That's 31 years. I had a 31-year birthday for methotrexate and RA. And that's still in the game. The other drugs, the other older drugs, are still in it a little bit, but there's so many new things to go do. And of course, the biologic agents, meaning the TNFs, when these two UFOs landed on Earth, Remicade and Enbrel, it just changed my world. And and then the biologics became used for psoriasis, and look at that's a horrible illness, and now these people are getting great treatment. And who would have heard of psoriatic arthritis 15 years ago? And then the golfer Phil Mickelson comes out, he's on Enbrel, he's getting that, and he's sort of made now people are coming out of the woodwork. Well, I've got psoriatic arthritis. So yes, the biologic agents are the big ones, and now we have these new, what they call small molecules, these JAK inhibitors. They're pills. They're not biologics, so there's none of that injection headaches. And they can be made in a factory. You don't develop autoantibodies to them. That's another big progressive drug. And then now we have another drug for gout, trophaceous gout, where they get the big white bumps on the skin, severe gout. We have a drug called Cristexa. That's an enzyme that is replacing an enzyme that we lost in our hereditary that gets rid of uric acid in pretty much anybody. So then now we can have an IV infusion for that. So all those things are great. But the electronic ability to get information for me is a real game changer.
Absolutely, yes.
Very exciting.
Well, I think it's probably time to pivot to address the elephant in the room, and that would be what all of us are experiencing these days with the coronavirus, COVID-19, and how it especially affects our immunocompromised population. Could you speak to that, please?
I can. I mean, this COVID-19 is a new player on the in the infectious disease world. So we don't have a lot of information for COVID-19, but for our patients that are taking immunosuppressives, so that takes the osteoarthritis and gout people. They're sort of in the non-autoimmune area, but for the rheumatoid and the lupus and mixed connective tissue people, certainly it's certainly an area to be concerned. They are immunosuppressed. That means the immune system has been weakened, and that helps control the autoimmune arthritic condition, which is the good news. But the bad news is that if you are infected with any kind of infection, your immune system is impaired, and it's not going to work as well. So you're more likely to get infections, and when you do get infections, they're likely to be longer and more robust infections. So that's all I can really say about that. The recommendations are still the same: hand washing, social distancing, respiratory precautions, staying at home. I mean, that's about the only thing you can really do.
So
Go ahead.
I'm sorry. Do you feel that there will be a new normal? There is a new normal then for compromised patients?
I think so. I think that until if they can get an attenuated vaccine, that may help everybody. But it's going to be a while before this thing sorts out. So yeah, I think that we may be getting going to restaurants, and people are going to be wearing masks, and they have a waiter with mask and glove on. I mean, it may be like that for quite some time. But go ahead.
No, please.
So that brings me to the point of what am I going to do as a patient, or how am I going to advise my patients about their medication? So if the patient gets COVID-19 and has a case of it, obviously, that's the easy answer, is we're going to have to stop the treatment that suppresses the immune system until the patient recuperates. Now, the patient that tests positive for COVID, but has no symptoms, is not an immunosuppressive, here's where we get into the gray zone. So it's probably going to be up to the patient and their provider of what they're going to do about that. Are they going to stop the medication in case they get it, or are they going to keep taking it because this is the fourth medication I was on and I was bedridden for a year before I got on this stuff? I'm not giving it up. So I mean, it's going to be in the gray zone, and it's going to be a personal decision between the patient and their provider, with the patient having the last word. But that's where we get into medicine, which we say is an art form that uses science as a tool. So this is going to be the art of medicine based on the patient, their condition, and their medication.
Absolutely. Dr. Reardon, I know we have covered an enormous number of topics today.
We have.
Yes, we have, and you have left no stone unturned, quite honestly. What would be your advice for folks out there who are affected with arthritis and loved ones of those with arthritis, battling this day in and day out?
I would say, and I know I'm repeating myself, but it bears repeating, your body is your temple. Do the best you can to take care of your body. That's what I'd say. More exercise, less weight, better diet, portion control, avoid injuries, be careful, even avoiding falls. Falls are a real, problem with it. So protect your body. Do more for yourself, or do as much as you can for yourself, and that will make with the diet, and the exercise, and the stress control, you're going to feel better, and you're going to feel more confident, and you're going to, actually the treatment will probably work better that you're getting from your rheumatologist.
Absolutely. Well, Dr. Reardon, thank you so much. You are such a large supporter of the Arthritis Foundation. You're involved with our walks. You're involved with our P4P program, Partners for Patients program, and you've just been such a long-time supporter of our foundation and all that we offer to anyone in need of programs and services, etc. So I appreciate that. And thank you for mentioning our website, arthritis.org, as well.
My pleasure. And thank you for having me. It was a lot of fun, and I hope we got a few points out to our listeners.
Again, yes, this has been enormously helpful for me, and I can only imagine our viewership will so appreciate your expertise, your sharing of your knowledge. And folks out there, again, Dr. Edward Reardon is based in Warwick, Rhode Island, a rheumatologist for more than 30 years. And I want to thank you again for your time and your expertise sharing today.
Thank you very much, and see you later.
Thank you. Okay, bye everyone. Thank you.